Welcome to the DRAL module. This module is set up for individuals who work at LifeShare in a clinical setting, but will not be filling out the DRAL themselves. DRAL stands for the Donor Risk Assessment Interview. The definition of DRAL is a documented dialogue in person or by telephone with an individual or individuals who are knowledgeable of the donor's relevant medical history and social behavior. While you will not be performing the DRAL, it is important for you to be familiar with what the DRAL is and why we use it in the screening process. For the organ team, it's important to note that the DRAL is mainly done in person in the hospital setting, and for the tissue side, the DRAL is done over the phone. There are several purposes to the DRAL, including one, to help in identifying the presence of potentially transmittable disease processes. Two, it allows for a full disclosure of accepting transplant centers and recipients. The third is to identify any increased risk behaviors. And lastly, it is required to release any tissue for transplantation that is recovered. The DRAL is one of three ways we try to compile a complete donor picture. The other two are the medical records from the hospital or any care facility the potential donor was seen in. And the last is the physical assessment or examination form that is performed by LifeShare staff. Using these three items together, a better whole picture can be created to determine eligibility and suitability of the donor for transplant. So a brief history on the DRAL. Before the DRAL, each organ or tissue recovery agency had their own questionnaire to assess suitability and or eligibility of the donor. There was a lack of uniformity and standardization across the nation, and the content and format was never evaluated, and the language was never evaluated for comprehension. In 2007, the FDA released guidance for the tissue industry when it comes to screening. In response to this, a task force was created called the Uniform Donor History Questionnaire for Organ, Tissue, and Eye Donors. This task force takes regulations from whole alphabet soup, including the AATB, which is the American Association of Tissue Banks, AOPO, which is the Association of Organ Procurement Organizations, EBAA, which is the Eye Bank Association, and FDA. There was also other commenting people, including UNOS, AST, ASTS, HRSA, NATCO, and probably a lot more. Many of you may not know all of those abbreviations. In this industry, you will soon get familiar with them. And while this task force did start in 2007, it had several drafts along the way, but the full tested and finalized version was actually not released until 2014. So if you don't take anything else away from this course, please take away these two things. This is why we do the DRAL, and this is really why we do what we do. So the purpose of the DRAL is that we owe it to the donor and the donor family to do everything we possibly can to honor the gift. But on the other hand, we also owe it to every single organ and tissue recipient to prevent disease transmission and keep them safe. So we want to get as much information as we possibly can to do those two things simultaneously. So in order to honor the gift as much as possible and to the best of our ability prevent disease transmission, a proper historian is key. The single most important factor is that an interviewee knows the donor well enough to answer the question about both medical and social history, from beginning of life to current. So the accuracy of the historian cannot be overemphasized. Take a 25-year-old male, for example. The legal next of kin is the mother. While the mother might have the best details for his younger life, she might not know details about his adult social life. The roommate or the significant other might be better suited to answer some questions. There are hints that the historian may not be reliable, such as responding as unsure often or hesitating for periods of time. But be aware that multiple DRAs can be done on a single person, and we can always ask the legal next of kin if there's anybody else more knowledgeable to talk to. There are also different types of DRA, a child DRA, an adult DRA, and a birth mother DRA. The adult and child DRA are used for organ and tissue donors, while the birth mother DRA is used for birth tissue like placenta donation for live patients. Also with each DRA, there's infectious disease addendums. The infectious disease addendums have all been added at different times after the final version of the DRA was complete in order to gain more information about the potential risk factors for certain diseases that were arising around the world. So far, we have 3 addendums, and that's for Zika, Ebola, and the most recent one, of course, is for COVID. So common things to follow. While this is mainly for the interviewer, it is still valuable to know what people follow when they interview the family using the DRA. The DRA is written in a very specific way. If you have not seen the DRA, I encourage you to ask your preceptor to pull one up and go through it. Once you look at it, all the things you must follow when conducting a DRA makes a lot more sense. Things to follow are: bold type print must be read verbatim. All questions must be asked in their entirety, including the examples in the question. Anything in italics is actually not required to be read. It is there just to help you facilitate the conversation and or gather more information. When a question has multiple parts, the best example of this is question 6. Each of them must be read individually. Do not lump them together. This is important to ensure the historian hears and responds to every single question being asked. Another thing in the DRA, you can only document what the family tells you, and it's best to make sure you get a yes or no answer. And then when typing in the DRA, try to stay away from vague language like a few, a couple, several. Get the historian to give you a number as accurately as possible, just because a few, a couple, and several can mean different things to different people. So the DRA is very comprehensive. It consists of 49 main questions plus the addendum questions. However, if a question is answered yes, then there are several follow-up questions to help provide more detail and clarification for the answer. So the DRA could potentially be around 100 questions. The follow-up questions range from who, what, how, when, where, the amount, duration, and much more detail for each question. So the DRA can be many more questions. The DRA has been tested and validated and aims for complete comprehension by the historian and is designed in a way to spark recollection when asking those questions. A lot of the questions are similar to those that when you give blood, so that's how detailed they get. The DRA does a deep dive to find any relevant medical history or social behavior that would impact donation. The DRA is very similar to the one, like I said, when somebody gives blood. As stated before, the DRA is used to identify the presence of potentially transmittable disease, and some common themes throughout the DRA to help find out information or evidence of communicable disease, high-risk behavior, exposure to all of those, and other disease processes. The DRA is also used to determine the quality of organs and tissues that could be recovered for transplant. Some items for this type of screening are included in the DRA, such as steroid use, if the patient is non-weight bearing or non-ambulatory, or they were a heavy drinker, and many more such examples. So while the DRA may seem long and inconvenient, it is very important for assessing the suitability, eligibility, and quality of the donor and the tissues. The DRA is an important piece of the information to get the whole donor picture. Even though you will never be conducting the DRA, it is important for you to be familiar with why we use it and the important and how it can impact allocation for both organs and tissues. And just to repeat myself one more time, always remember the reasons we gather so much medical information is that we owe it to the donor and the donor family to do everything we possibly can to honor their gift, but we also owe it to the organ and tissue recipients to prevent disease transmission. So that's the DRAL in the nutshell. Again, if you have not seen a DRAL, go ask your preceptor to pull one up. It is very, very important to use that for all tissue and organ allocation and to determine suitability. Thank you guys, and good luck on your orientation.